Good afternoon, everybody. Thank you for taking time to be with us today. As Sherry said, my name is Dr. Peter Entwistle, and Dr. Anne-Marie Kimball is doing the chat room, and she will also do the second half of the presentation today. It's important for you to note that by way of disclosure, we are both full-time employees for Pearson, and those are some of the instruments that will be mentioned during the presentation today. Let me give you a little background about Dr. Kimball. Like myself, she is a licensed psychologist, but she also has a certificate of proficiency in clinical geropsychology. Her counseling psychology PhD comes from Texas A&M, and she has worked in the Texas Department of Protective and Regulatory Services, as well as having done a clinical internship and postdoc at the VA system, where she served as a staff psychologist for a number of years. So she has provided clinical services to geriatrics, palliative care, rehab, neuropsychology, and post-traumatic stress. And I'm thrilled to have her on the presentation today. So next slide. What are we going to cover? This is, in general, what we will do. We're going to try to take a look at the role of psychological, social, and behavioral variables in the surgical process. So what we're going to do is look at what factors reduce the risk of poor outcomes or increase satisfaction. We'll also explore the topic of pre-surgical assessment and what you as psychologists can do, and what kinds of information you're going to be able to get from these tools to help you with your report. Now, what we do know right now in the 21st century is that medical diseases affect millions of lives. So next slide. And it costs billions of dollars. We've seen healthcare costs for management or chronic diseases become astronomical, and a substantial portion of that healthcare cost, particularly in the U.S., is for conditions associated with psychosocial sources. So that's our focus. Now, in terms of prevalence, what we do know, next slide, is that among patients with heart disease, such as coronary artery disease or heart failure, it's very common to have anxiety and depression. And as psychologists, we can understand that, because if you've been well a large part of your life and all of a sudden you're struck down with a heart attack, or perhaps you're experiencing problems, it is like a changing event, because all of a sudden life seems to become short and you are vulnerable and you are at risk. And so a number of these patients have depressive symptoms, and it's suggested by a number of authors such as Tomes and Rutledge that it could be as much as 20 to 40% of individuals with those medical conditions have depression. And indeed, Huffman, Solano, and Beach even argue that 15 to 20% suffer from major depression. However, anxiety may be even more common than depression in some of these same patients, and it was suggested that over 50% of individuals with heart failure have very high rates of anxiety, and 13% meet criteria for an anxiety disorder. So what's the take-home message? Very simply, if you have an individual who's at risk for medical problems such as heart disease, or perhaps stroke, or perhaps they have lung disorders, that patient may also have a high degree of depression and anxiety, and it lasts. It persists over a year, according to research by Martins and others. And if there is a myocardial infarction, depression tends to persist as well. So what we do know is that individuals with medical problems are at high risk. And so when we ask the question of what do they bring with them to the hospital, bear in mind if there is a history of coronary disease or perhaps of stroke or some other medical problem, it is very likely that there's a high comorbid presentation of a psychiatric problem. So when we think about this general topic of a pre-surgical evaluation, I'm going to ask you, what's the goal or purpose? What's it for? Is it to prevent the wrong candidates from getting surgery? Is it possible that we're having individuals that say, I want to get this surgery, I know that it's going to be helpful to me, and I want to get that? And so we are acting like a gatekeeper, trying to identify individuals that might actually require the surgery and prevent and perhaps protect surgery for those that need it. Or is it to ensure that there's a successful surgical outcome? And a question might be raised as, well, if you have a good surgeon, particularly if it's a teaching hospital and this is a person who is established on the faculty and perhaps they've written research articles and so forth, that's all you need? Or is it possible that there are psychological factors that actually may adversely impact that outcome? And one reason why I raise this subject is that many years ago, a colleague of mine from Boston College was doing research at Mass General. His name was Harry Sobel, S-O-B-E-L, and he looked at MMPI reports of patients that were going to be experiencing heart surgery, and what he found was that many variables on his psychological tests predicted outcome. And that wasn't something that the surgeons really wanted to recognize or pay credence to. But since that time, clearly we're looking at psychosocial issues that could have an adverse impact on surgery. And so one of the goals really is to identify those factors that are going to enhance or reduce the outcome. Next. Now, you may ask, well, what types of surgery are we talking about? And you'll be interested to know that when we've asked our own customers, that is psychologists, these are the answers they gave us. Some clearly have a practice that looks at the subject of pain. And in some cases, they're looking at spinal cord stimulator, not unlike the work that Block does. In other cases, they're being asked to evaluate patients that are candidates for bariatric surgery. And so for some of them, the question might be, is there a link between obesity and some other psychiatric problem? And what kinds of assessments might be appropriate for that candidate? And I did review that myself previously. Sometimes psychologists tell us they have to do evaluations of candidates for organ transplant, or perhaps patients with cardiac problems, or individuals that may need a hip or knee replaced, or who have problems with sleep. So there are a number of different types of procedure that our psychology customers tell us that they have to be involved with. Next. So, when you think about billion-dollar questions in medicine, the first general classification would be what patient characteristics predict good outcomes, optimal medical outcomes. And the second general theme would be what psychosocial processes reduce the success of those treatments? What should we pay attention to? And clearly, if someone has a psychiatric problem, or perhaps they have a negative outlook, or perhaps negative health behaviors, or risky behaviors, that's going to adversely impact them. I had a surgeon one time say to me, I tried to evaluate the patient psychiatrically, and I check on their alcohol and substance abuse and their risky behaviors, and what I find is sometimes I don't always get a clear or straight answer. Now, on the other hand, are there techniques that could be used preventatively to be able to optimize the outcome? And the answer is we need to explore that as well. Next. So these are the questions that we think you need to ask. What patient characteristics bring people in the first place? Which of these can work for or against the success of a medical intervention like a surgery? And how can we assess those characteristics in a reliable and valid way? And if we have evaluated that candidate, how can we change characteristics that are modifiable? In that case, can we better prepare them for the surgery ahead? And I do know that there are times when an individual might consider, for example, bariatric surgery because they have experienced a long history of obesity and they want to try to get rid of that problem because of the associated medical issues such as hypertension and possible stroke and heart disease. And so one of the issues may be, well, have you been in psychological treatment previously? Have you tried a weight loss program? Have you been on a diet? Have you been exercising? And so when you look at the patients that may come to the healthcare setting, it's very likely that you're going to have a number of different areas to explore with those very same patients. Are there factors that are going to preserve the patient's health? So if the person engaging in risky behavior, are there health behaviors that are preventable? And when you look at what is going on with this particular patient, how are they responding? Is there an emotional response to a diagnosis? Let's say someone has been diagnosed with a medical problem. How are they reacting to it? And are they able to adjust? And exactly what is the nature of that disease? So if they are experiencing pain, perhaps due to some trauma that they've experienced, what's their reaction? Do they just accept it with resignation, or are you finding that perhaps there's a passive willingness to accept what's happened? What we do know is that individuals that are looking for medical attention will often pay visits to the ER. And in the time of COVID right now, that may be a real challenge, because when the person comes back because they feel that their problem hasn't been solved, are they able to get the treatment and the evaluation that they're looking for? And clearly we need to look at what are some of the factors that are going to influence recovery. They tried something, did it not work before, and is that stopping them from going to work? Next. So there are some psychosocial factors and health issues that we need to explore with our patients. As I've said before, we see a number of individuals with medical problems who have a high rate of comorbidity of depression and anxiety. As they look at themselves and they appraise their cognitive status, do they appear to be efficacious? Can they take care of themselves? Do they feel like they're in control and they're optimistic about the possibility of a good outcome? And what strategies are they bringing with them? Are they actively involved? Are they in denial, like this really isn't a problem, I want to minimize it? Or is it possible that they actually need to explore what resources do they have available to them at this time? What's the family like, and how much support can they offer? And in addition to that, what kinds of spiritual or economic support are they experiencing? Because a number of people today have lost their job. They're unemployed, and they may not even have health insurance. And so an adverse impact of the current pandemic we're going through is to change the resources that may be available to somebody. Furthermore, we may also see that they're experiencing a lot of stress at this point, and a big challenge to how do I manage and how do I keep on? How do I function if I have to continue to self-isolate? Next. So, one of the questions that I'm sometimes challenged with is, how do I evaluate some of these patients that are showing up? Can I just simply do an interview? I had a bariatric surgeon one time who said to me, well, I tried to evaluate them. I tried to do an interview, and sometimes they pass the screen, but I am wondering if that's going to be good enough. And I had one person say, well, I refer them to a psychiatrist, and it's not very helpful because sometimes I get a report saying this patient's non-psychotic. Well, that's not very good. Are there other things you need to know? And in some cases, is it possible that you're not getting all the information? Is it possible you could be fooled into thinking somebody could be compliant with the doctor's orders when they're not going to, because they're just telling you what they think you want to know? So what are those psychosocial factors that influence the outcome? I had a surgeon one time who said, I did ask about alcohol and drug abuse, but I didn't get a very honest answer, and now I'm worried that this person may be a candidate for other medical problems. And so the question might be, am I doing a screening that's thorough enough and takes into account some of those factors? And when we think about that in today's society, how is our practice different? How has it changed? And could that COVID-19 virus make a difference in what we do? And of course the answer is yes. So what does APA say about that? One reference I want to make is the work of Andrew Block and others that was part of the APA statement in April. And this is in general what he was saying, that he knows we have to do these psychosocial evaluations, we need to look at their strengths and assets, and we also need to take into account how the pandemic may affect the patients that we're dealing with. Although it's stressful for everybody, are there some who are increasingly at risk because of social isolation or perhaps the physical conditions they're going through? So Block's first point, his recommendation is, be aware that there may be an emotional distress displayed by certain patients that's directly resulting from the COVID crisis, and that this too will pass. But it's possible, as we start to do remote assessment of patients, that some are going to underreport what is going on in their lives, and others might think, well, I need to really over-report, so I'll get the surgery that I'm looking for. So we do need to look at the whole issue about how much psychological distress is being evaluated and reported, and is there a tendency perhaps to minimize the patient's problems because they're thinking, well, if I can do that, perhaps I can show myself to be an appropriate candidate. What we also know is that since some of the hospitals are focusing a great deal on the COVID patients, so they're minimizing the number of patients that may be coming in for elective surgery. And what may be considered elective in some cases may also be considered very important and necessary for some of the patients that experience those problems. So the question is, can we mitigate potential symptom validity? Can we take into account how accurate the patient's statements about themselves are? And can we evaluate the validity of those responses? And as Block said, you can look at indices on the MBMD-RF or the BHI, as well as look at collateral supporting medical records to determine if a patient is particularly distressed at this point. What do their records say? What is their history? And have they complied previously with medication use? And are there relevant factors that a doctor needs to take into account? So it's very important to get all of that information, if possible, whether you're working with a child, an adult, or a geriatric. Next. So one question that comes up is, if the patient has a medical problem that requires surgery, but it can wait, should you wait to do the evaluation? Some surgeries are time sensitive. For example, if a patient has cancer, you can't wait, or if the organ's going to fail, it's important to evaluate them now. So it is important to look at what procedures are planned and how soon is that going to be. Is there going to be any kind of a delay in the actual timing of that surgery? And are there supports that are available to that candidate afterwards? Next page. Is the entire process reliable and, for that matter, valid? So one thing we need to pay attention to in doing remote assessments is that we may not be able to do the same comprehensive or thorough battery we may have recommended or wanted to do previously. We have to recognize there are limitations. And although there's no strong research base for some of these tests, it doesn't necessarily mean that scores we obtain remotely are therefore invalid. It may just be that we need to collect more data to be able to assure individuals that we're getting the whole picture. And we need to be able to look at what that patient's environment is like and whether we can get the kind of information we're looking for in that in-person administration. In addition to that, we may need to make sure that we get a consent form signed by the patient and the family to protect item test security, the credibility of responses, and we may also need to have a camera on that patient as they complete the evaluation for us. We want to make sure it's quiet, secluded, and that there aren't other individuals in the room that may be distracting that person, as you can imagine. So Pearson does have some guidelines for that process. Again, the question might be, Can you maximize the potential for validity? Can you get the collateral information you need? Do you have the ability to interview family members who are well informed about the status of this particular patient? And can you go ahead and do the kind of evaluation that may be very helpful to you and to surgeons to be able to get the information you need? When you draw on conclusions based in part on psychometric test results, remember they weren't initially evaluated for telehealth application, but there are a number of psychologists around the country doing this, and APA has actually suggested don't be too impulsive or quick to return to your former way of doing things. It may be more secure and safer to continue to do remote test administration, but as we note here, it's very important to follow your national and state organization guidelines and any local regulations that may apply to you. Next, is it possible that some insurance requires a pre-surgical evaluation, a so-called PPE? And the answer is yes. Sometimes they will say to a surgeon, you can't go ahead and do this without getting an evaluation beforehand. And certainly when we look at other insurance plans such as Medicare or workman's comp, they may place a lot of emphasis on the need for an evaluation to ensure that this is a candidate who is going to be appropriate for this type of procedure. So again, we need to look at what are those factors that predispose a person to a successful outcome, what's going to preserve health, and can we identify how well adjusted a person's going to be. So these are the areas, as we've indicated before, that are important to look at. Are there affective or psychiatric disorders such as depression that may be very important to attend to? As we look at the person's ability to do cognitive appraisals and their ability to look at the situation and recognize what's going to be done to them and what needs to happen, are they fully informed? And can they cope? Do they have the resources to be able to manage the stress of that surgery? And do they have the ability to manage the context when they're trying to recover? Next. So one of our authors talks about the need for a pre-surgical psych evaluation. And you'll have to excuse the pun, but clearly that acronym stands for something else these days, and that has to do with personal protective equipment that so many of our essential healthcare workers require in order to manage the COVID virus. But in another way, kind of ironically, it also applies to psychologists because it's really a question of risk assessment. Can you form an evaluation of a patient that takes into account risk? So in a way, you're not looking at protective equipment, you're looking instead at an evaluation that's going to look at risk. So it's going to elucidate the psychosocial factors that may adversely impact the results of a surgery. And that's very important for doctors to be aware of. And what are those factors in context, and also what treatments may be needed to mitigate and augment surgery, or perhaps that need to be conducted prior to someone undergoing this? And are there alternatives that could be considered instead? Next. So the PPE, or the evaluation, is going to look at elevated scores on scales, and these are empirically demonstrated to have had association with reduced surgery outcomes. So we've looked at data that's been collected over about a 30-year time span that has proven to be very powerful and predictive, and very important, I think, for psychologists to be aware of. And it's going to be important to look at how candidates for the same type of surgery have performed on this type of evaluation. Do we see any critical issues coming up, such as perhaps suicidality? And are we also seeing problems that might be presenting in clinical research that would have an adverse impact on the results of a patient? So, as one of our research authors argues, if you have 4 or more of these psychosocial risk factors, it can increase the presence of psychopathology and double the risk of failure. So we don't want that to happen. Let's see if we can identify them. However, in some cases, you need to take into account these psychological problems of high-risk patients prior to surgery so that it could therefore become more successful. So questions and answers. What psychological factors can work for or against? Are there medications that can be helpful? Can we as psychologists reliably and validly assess these characteristics? And can we rely on a multimodal instrument that's going to integrate that information for us? So here are some considerations, and in a minute I'm going to be switching to my colleague for her to continue the presentation. So the question might be, what was the purpose of the instrument when it was being developed? And how up-to-date are those norms, and do they represent the demographics of the patient population I'm dealing with? As we start to consider the patients we're working with, what's their attitude about injury and pain? What's their attitude actually towards their primary care doctor or the health system they're working with? Are they motivated to do well and to follow the doctor's directions? And are they actually able to participate in the recovery process? Do they believe that the surgery will actually lead to a positive outcome? And do they understand how there's a risk of failure? So we do need to look at all of these considerations as well as what the history of the patient is before considering that we have a complete or comprehensive view of the patient. So at this point, I'm going to turn you over to my colleague, Dr. Anne-Marie Kimball. Dr. Kimball, are you there?
I am. Thank you so much, Peter. I'm going to move forward with the slide. I want to talk a little bit about some of the instruments that are used in pre-surgical evaluations, and I'm really going to kind of focus on a narrow group, but we don't have a lot of time, so I'm just going to kind of cover some of the major instruments. When you think about those many costs and types of costs of failed surgeries, and as Peter mentioned, otherwise poor outcomes of surgery, and also understand the contribution of mental health on physical health, you really do then arrive at a place where you want to identify those risks and the positive attributes that could impact those successful outcomes. It makes for a much more expeditious and successful process. And as Peter mentioned, the literature suggests that psychological factors such as somatization and depression and anxiety and poor coping are really important predictors of poor outcomes following spinal cord surgery and other major surgeries. Patients who undergo consideration for several types of surgeries are often referred for a psych eval, as Peter said, as part of that process to determine their suitability and evaluate the likelihood of successful outcomes. Many clinicians and some insurance requirements really feel that an extensive psychological evaluation is warranted. And this evaluation then would include a medical record review, a clinical review, interview, and then psychometric testing that includes both narrowband tests, for example, mood measures and measures of coping strategies and things like that, and the more comprehensive types of assessments, such as those that assess personality traits and psychopathology and the biopsychosocial factors that can affect medical treatment. And those are the ones that I'm going to cover today. It really is important to consider, as Peter mentioned, the population for which the instrument is intended when you're making instrument selections. And that standardization population, and then whether there are additional normative or comparative groups to consider. It's important to address the questions of how your patient compares with other similar patients and how your patient compares with the average healthy person. A few tests that have been used for the assessment of medical patients attempt to address these questions by having multiple norm groups, notably the MMPI-2-RF, the MBMD, the Milan Behavioral Medicine Diagnostic, and then the BHI2. These tests all address this matter in different ways, though, as do many tests. The MMPI-2-RF includes spinal cord stimulator and spinal surgery norms. The MBMD uses general medical and chronic pain and bariatric norms. The BHI2 patient norm group utilizes a really diverse cross-section of patients in treatment for pain or injury, and that included spinal surgery patients, non-spinal surgery patients, interventional pain medicine patients, chronic pain patients, work hardening patients, acute pain patients, and brain injury patients. So it's really important that you select a test for a presurgical eval that does include instruments, again, that are relevant for the population for which you are using it or intending to use it, and instruments that are research-based and normed on relevant surgical candidates. It's also important to consider, as Peter mentioned, if the instrument has good reliability and validity, and predictive validity in this case, the length of the instrument, so how many questions or how much time to administer. Is this an instrument that can be administered only in paper and pencil, or is there computerized administration available? And at this point, in this current time, is there a remote administration available? What about computerized scoring and reporting? It's really some of the reports that are available for some of the instruments, and I'm going to go through some of those, really are comprehensive and of course, evidence-based, and those really enable collaboration across the multidisciplinary surgical and care teams. I'll show you more about that in a minute. So these are just some of the examples of some. These particular ones are all Pearson published instruments, or in the case of the MMPI2 RF, it's actually published by the University of Minnesota Press and distributed by Pearson. But these are instruments that we have, that we know a lot about. And excuse me, again, we know it's really important to assess these factors, as high levels of psychological symptomatology are often indicative of patient satisfaction and adverse or suboptimal surgical outcomes. So starting first with the Battery for Health Improvement 2, or BHI2. This is a 217-item self-report multiple-choice instrument that was designed for the psychological assessment of medical patients. And the purpose of this test is to provide that relevant information and treatment recommendations to professionals who treat injured patients in a variety of settings, including physical rehab, vocational rehab, and general medicine. The BHI2 test was designed for patients ages 18 to 65 who are being evaluated or treated for an injury. It's a really easy-to-administer test. It can be administered and completed in approximately 30 minutes. There are a number of different report types: profile, basic interpretive, enhanced interpretive, progress reports, and then a medical intervention risk report that I'll go through in a minute. Again, it has both community and chronic pain norms. It can be administered both digitally and via paper and pencil. And at this point, it can be administered via telepractice as well. And it is in both English and Spanish language. So the BHI2 originated with a paradigm that the authors, Dan Bruns and Mark DeSorbio, called the vortex model. And this is a graphical representation of the biopsychosocial model as it pertains to the onset of injury or illness or chronic pain and intractable biopsychosocial disorders. And this model really attempts to organize what was known about how patients respond to health challenges and why some patients get into kind of a downward spiral of worsening symptoms. So again, the vortex model served as a guide for the development of the BHI2 and as a conceptual paradigm for performing a biopsychosocial evaluation in the clinical setting. So the BHI2 provides assessment of validity, physical symptoms, psychological, character, environment, and social factors that can impact the response to the normal course of treatment and recovery of patients who, again, are being treated for pain and injury. So it has use in the presurgical psych eval, pre-medical treatment psych eval arenas to help explore and to explain the interaction of psychological and physical symptoms. It is a standardized psychometric measure. It has 3 validity measures. It has 16 clinical scales and is a multidimensional assessment of pain. There's 18 overall scales organized into 5 domains: the validity scales, the physical symptom scales, affective scales, character scales, and psychosocial scales, as you can see here. You can see the names of all of them here. And again, it was normed on 2 large census-matched samples, a community sample and then a national sample of physical rehab patients. So it provides the clinician with information about how a patient compares to the average patient and to the average community subject. The average patient is used as a benchmark for the interpretations and recommendations, and that really reduces the risk that what is normal or expected for patients will be overpathologized or labeled abnormal. And then in addition to the community and patient norm groups, the BHI2 uses a variety of other clinically relevant reference groups for even more diagnostic specificity. So, for example, national samples of patients with chronic pain, head injury or headache, neck injury, upper extremity injury, back injury, lower extremity injury, etc., are also available for score comparison. So looking at those reports, this is not from any, well, it's from the overall profile report, but it is included in the other reports as well. I just want you to kind of see the kinds of graphics that are available in general. So, excuse me. As I mentioned, there's a progress report, which really just enables the clinician to monitor a patient's progress over time. I'm going to mute for 2 seconds. Hold on. Okay, sorry. Hay fever, allergies, I have no idea. Okay, so there's a progress report that allows the clinician to, again, monitor progress over time. There is a profile report that provides this, as you see here, this graphical representation of the patient's raw and T-scores in comparison to both the patient and community norms, as well as the patient's rating in percentile. And then, of course, there's a section on validity issues, critical items, content areas, omitted items, and item responses. There's a basic interpretive report that includes everything you see here and some additional, treatment recommendations, a patient summary. It has, it provides a concise interpretation of all the test results, not just the profile graph. And then an enhanced interpretive report that provides an even more extensive interpretation of the patient's results, including really in-depth scale category narratives. Has all of the components of the basic interpretive report, also includes a section on somatic complaints, item responses, and then diagnostic probabilities. And as I mentioned, they all begin with this patient profile that you see here, and below the graph on the report, I cut it off on this picture just to make the picture as big as possible, but on the report there's information on interpreting the profile. For example, the scale is considered to be average if those diamonds that you see are only within the 40 to 60 score range. One diamond outside the range might indicate a moderate elevation or more symptoms than a healthy person or an average community person, and then two diamonds outside would indicate a clinical elevation, more symptoms than other patients, as an example. So you can see there the patient profile. And then you can also see, sorry, I forgot that I put this in here. The gray section, the 40 to 60, is considered to be the average range. Okay, and then you see the scale summary. Again, this just defines and gives some information about the particular patient's noteworthy scale findings. And then each of the reports that have a validity narrative and a narrative about the physical symptom scales, as you can see here, so it would address whether or not the patient had endorsed any of the validity items and how they were endorsed, and then the physical symptom scales narrative, the pain complaints, item responses. Again, this is just to give you a look at what the reports look like, not to see all the details because I know some of that's hard to read. The somatic complaints item responses, you'll notice, though, that you can see if the patient response indicated that it's a big problem or a small problem. You might see also the third column over that for the somatic complaint listed in the first column that the patient endorsed, that there is a possible medical explanation for that should be considered, as well as in the last column a possible psychological explanation for the symptom. And again, those were somatic complaints. You'll see the narratives for the affective and character and psychosocial scales. And then the critical items. And this just is shown in the reports. And you see here, you see the omitted item because for something that is shown live and then turned into a handout, we can't put the actual items. But you can see that the areas of critical item. And if you were looking at a report, you would see what the actual item was and then the patient response. So for this one, there were critical items endorsed in the areas of compensation focus. And there is a question in the chat box that I have not had a chance to get to in chat box, but it asks about whether or not there's different considerations or areas to focus on for people who are paying for their surgery out of pocket or those who have it covered by insurance. This is not directly related to that, but it is kind of related in that for a person for whom the finances or a compensation is something that is important, if there is a compensation focus for this patient, you're going to find that here. Again, I know that that's not directly related to whether or not paid for by insurance or not paid for by insurance, but it made me think. Okay, and then a graphical look of all of that information that I just showed you, the narrative to, the physical symptom content, the affective, the character content areas, psychosocial content. You can see, again, the graphical look with the same kind of diamond and descriptive, the content area rating, very low, low, typical, high, very high. And then, as I mentioned, there is a report for the BHI2 that can be run that is called the MIR. It is the Medical Intervention Report. It's the newest report available from the BHI2 data. Again, it stands for the Medical Intervention Risk Report. And that's a computerized interpretation of the BHI2 biopsychosocial assessment for medical patients who are being considered for treatment or rehab. And this report, this specific report, highlights the risk of specific medical interventions for pain, specifically the risk of surgery or rehab or opioids. So, while the BHI2 reports are used in a comprehensive psychological assessment, the MIR focuses on the degree of risk for poor response to medical treatment, including surgery, to determine those risk factors that are thought to negatively impact a patient's response to medical treatment. And it was created to assess that risk of failing or being unlikely to benefit from those costly surgical interventions that, even with successful medical outcomes, sometimes don't translate to improved patient functioning or reduced pain medication or patient satisfaction. I have also often heard Dr. Bruns talk about how frequently that is the case in post-surge evaluations, where the surgeon will consider that the surgery was absolutely successful. From a surgeon's standpoint, it went smoothly. The physical change in the patient is 100% what the surgeon was looking for, but the patient has not changed their report of satisfaction. That's very often the case, and is attributed to these biopsychosocial factors that could have been potentially mitigated from the outset if somebody had been aware of them. And so again, it's created to assess for the risk of failing or being unlikely to benefit from those costly surgical interventions that, even with successful medical outcomes, don't translate to improved patient functioning or reduced pain medication, patient satisfaction. Also, rehab due to non-adherence to the long-term commitment, or unlikely to benefit from commonly prescribed opioid narcotics due to significant risk of aberrant or ineffective outcomes such as addiction or overdose or increased disability. And then also this report helps providers meet that evidence-based medical treatment guidelines that are outlined for good clinical practice, and supplies needed information for insurance approvals and workers' comp, and for just general reimbursement. So the BHI2 Medical Intervention Risk Report, again, it was adapted from the existing BHI2 test, authored by Drs. Bruns and DeSorbio. It was designed to support decisions that medical providers make for pain interventions. And it offers 5 risk factor scores. So it helps you answer some of these questions that you see on the screen, and it does so with these 5 risk factor scores: a primary score, primary risk factor, a pre-surgical, rehabilitation, addiction history, and addiction potential. I'm going to show you some of this in the report. So this is just, the 5 pages. These particular, it's just a screenshot of the 5 pages. Let me show you a little more in depth. So this is just a graphical profile which really succinctly summarizes the patient scores on the 5 psychosocial risk factors, and 2 non-adaptive coping styles that you can see here. There are interpretive statements in the report that are offered for each of the scores, and then a final section that provides recommended interventions to reduce risk and highlights patient strengths. So you can see it begins with the validity measures to assess how the patient approached the test and assesses bizarre responding or minimizing or magnifying. You can see this one just shows self-disclosure score that's within the average range. Shows that it's a valid profile. And then the outcome risk level here is considered to be very high. There's a narrative process that will explain that. Then there is also the primary or the risk factors here on the left side, beginning with the primary risk, which looks at severe factors such as suicidality and violent ideation, psychosis, thoughts of retribution toward physicians. The pre-surgical risk area assesses also suicidality, violent ideation, psychosis, and risk of retribution toward physicians. The rehabilitation risk assesses a broad band of secondary risks that have been associated with poor response to treatment, such as depression, anxiety, pain tolerance, anger, and then addiction history looks at multiple historical risk factors such as anger or trauma that are known to be predictive of aberrant or otherwise problematic drug-taking behavior. And then addiction potential assesses a variety of current pain-related risk factors like pessimism and expectations about pain associated with the desire to use opioids and other pain-relieving medications. And then there's a narrative. Forget that I put those in there. Our previous platform did not allow for those kind of transitions, and I forgot that I put them in my slides. Okay, so then there's the narrative, again, that goes along with each of those sections. And then this report ends with the non-adaptive coping styles, so indicating whether or not a person is scoring high on catastrophizing or kinesiophobia. Catastrophizing, assessing the tendency to believe a situation or symptom is far worse than it actually is, and kinesiophobia assesses the belief that a physical activity is likely to lead to pain or harm and thus should be avoided. Okay. And then the narrative, again, for those sections. And then there's a section on recommended risk reduction interventions and patient strengths, psychological treatments, inpatient strengths here. And then just to mention this, there is the BHI2 has a companion short form called the BHI2, so the Brief Battery for Health Improvement 2. I needed to include that just to let you know that. I often hear people get those mixed up, and so I just want to point out that the BHI2 is the briefer battery of this. It does not have that mirror report to it, but it is a very similar instrument, just in a much briefer form. Okay, I want to tell you about the MMPI2 spine reports really quickly. I'm realizing how short of time I really am, so you guys are probably all familiar with the MMPI2. I'm not going to go all the way through this, but I want to tell you about a couple of the reports that are available from the MMPI2-RF. You know the MMPI2-RF as an instrument that aids clinicians in the assessment of mental disorders, identification of specific problem areas, and treatment planning in a variety of settings. These two newest, they're not brand new, but they are the newest reports for the MMPI2-RF, are the Spine Surgery Candidate Interpretive Report and a Spinal Cord Stimulator Candidate Interpretive Report. And these were developed using extensive empirical research, and they assist psychologists in pre-surgical evaluations of patients who are being considered for spine surgery and spinal cord stimulator surgery procedures. They're highly evidence-based reports. They include full scoring information and integrated interpretation of scores specifically for pre-surgery evaluations. They compare a candidate's test results to those of more than 1,800 spinal surgery and spinal cord stimulator surgical candidates, and they identify psychological risk factors from 9 problem domains: demoralization and depression, pain and somatic sensitivity, pain coping, health orientation and medical adherence, anxiety and stress, fear and avoidance, interpersonal, substance abuse, and a recovery disincentive. And these reports also highlight areas of increased post-surgical risk relative to other candidates, as well as provide associated treatment-focused recommendations that are specifically for these pre-surgical populations. Both reports provide comprehensive annotations and research references for all of the interpretive statements as well. And again, an important feature of these reports is the use of data from comparison groups made up of individuals assessed as part of presurgical evaluations for spine surgery and spinal cord stimulator candidates. These reports differ from the other MMPI-2RF reports in that their focus is on the implications of MMPI-2RF findings for surgical patients. So they provide guidance on identification and interpretation of the test taker scores when they deviate substantially from those of the relevant comparison group, as well as a description of the empirical correlates of such findings. So for both the empirically valid presurgical assessment report and it indicates elevated scores on those scales that have empirically demonstrated association with reduced surgery outcomes, compares patient scores to other candidates, as I mentioned, and then through clinical correlate research relates scale score elevations to other psychological constructs that are known to impact surgery results. It forms the foundation for integrating results in order to determine overall level of psychosocial risk, and it identifies those areas or expected areas of reduced outcome, and again provides treatment recommendations. These reports provide 3 levels of risk information: substantive scale interpretation, which compares scores to the normative sample, not to spinal cord stimulator or spine surgery patient, and these are relevant to psychological diagnosis and consideration of major psychopathology. And then comparison group findings that compares to the candidates of the same surgery type and are most relevant to determining poor outcomes. And then also the presurgical psychological risk factors section, which consists of interpretive statements that are supported by the empirical studies that are referenced in the spine surgery report manual. And I mentioned that these statements are all organized by the 9 problem domains. And these statements are triggered when those scale elevations have an empirically determined relationship with those established risk constructs. So they're considered the most relevant to determining overall risk treatment recommendations. As I mentioned, the 9 problem domains represent the major psychosocial areas that have been found in the research literature to negatively impact the outcomes of spine surgery and spinal cord stimulation. Here you can just see the RC scales that are considered to be most strongly correlated with spine surgery and stimulator outcome. Here are the supplemental and Psi-5 scales, again also strongly correlated with surgery and stimulator outcome. And then this is what the annotated reports look like. I'm not going to go through these in detail either. I just want to, again, give you a look at them. You can find these annotated sample reports on the Pearson website if you'll find the MMPI2RF page and look for sample reports, look for the spine reports specifically, and you'll find these that walk through, what information is available on the test. It is the very thorough information that you're used to seeing on any MMPI2 report, but of course, as I mentioned, geared towards spine report or spine simulator candidate report. Okay, so let me hop to the MBMD real quick. It's still just, they're very long and thorough and extensive reports, all with established research references annotated. So looking at the MBMD, this is the Milan Behavioral Medicine Diagnostic. It's a self-report assessment that helps identify psychosocial assets and liabilities that may affect an individual's response to surgery or the course of medical treatment. The MBMD, as you probably know, was developed by Dr. Ted Milan, the author of most of the Milan instruments. The MBMD is based on a comprehensive review of literature, input from experienced practitioners, and then, of course, extensive reliability and validity data. It assesses negative health habits, psychiatric indications, coping styles, stress moderators, and treatment prognostics, and so it helps provide a really broad understanding of the personal reality that each patient faces, which really helps the clinician to develop tailored treatment recommendations. It is brief, yet comprehensive. It has 3 norm groups, one that includes a comprehensive sample of patients with chronic medical conditions, one specific to bariatric surgery candidates and one specific to patients with chronic pain. The chronic pain norms and the pain patient reports can assist, again, with pre-treatment psychosocial evaluations. The bariatric norms can help determine a candidate's psychological suitability for bariatric surgery, also assist patients in making significant lifestyle changes to help make those surgeries more successful, and prepare medical staff to respond to patients' likely reactions following surgery. The MBMD's general medical normative sample permits the test's use to be extended into a variety of settings, including places like sleep disorder centers, cancer treatment centers, cardiac rehab, neurological rehab units, military and veterans hospitals, primary care facilities, etc. And the interpretive report includes a healthcare provider summary that's written in language that medical professionals readily understand, and that really helps to facilitate communication between the psychologist and the medical staff. So there's 165 items, requires only 20 to 25 minutes to complete. It helps to reduce the patient resistance and fatigue. Like other personality tests, the MBMD provides information about a patient's coping style, but it also provides scales like stress moderators, treatment prognostics, psychiatric indications, and negative health habits that are worthy of the clinician's attention. Again, the interpretive report takes each patient's individual style of coping into account in mediating the patient's psychiatric symptoms, personal assets, and external resources, healthcare utilization. So the interpretive report really captures the process of synthesis that a seasoned clinician would use in integrating information from multiple test instruments. So it has applications in pre-surgical psychological evals, in identification of assets and liabilities that may affect the outcome of surgery or medical treatment, and treatment planning and recommendation. Okay, I think I said a good bit of this. Age range 18 to 85, reading level 6th grade, also available in Spanish, can be administered in paper or pencil or digitally. Mentioned the reports and the healthcare provider summary. So this is just a look at the model. It includes psychosocial characteristics that can influence health maintenance and healthcare costs, which in turn, of course, determine health outcomes. And then pictures of the reports that are also, you can find these on our website, sample MBMD reports, so that you can get a really good look at what the information available looks like and how it's presented. It, of course, covers the scales that you see here, the response patterns, negative health habits, 29 content scales made up of psychiatric indicators, coping styles, stress moderators, treatment prognostics, and then a management guide. And this is what, just a picture of the top part of the report where you're looking at the validity scales, the response patterns, and negative health habits. The graphical presentation of the clinical scales and the profile of the scores, the narrative portion that goes along with those. And then a look at just kind of how this is all synthesized in terms of the report, the cross-domain synthesis, how the domains are related to each other, and how they relate to the management guide. And then, again, there's a general medical, a bariatric report, and a pain patient report. Each of those includes that health provider summary, tailored, of course, to the specific report. We've included in the handout just a few additional instruments that are not as comprehensive as those three that I've covered, but are still very relevant for use in this area. The P3, the pain patient profile, is one that we've included, so you'll see this in the handout. And then and I realized this morning that I have this a little bit out of order. The brief symptom inventory is a brief version of the SCL-90R, which is in here in a couple of slides. And I usually show the SCL-90R and then the BSI, but it's in here. So the BSI, the brief symptom inventory, the quality of life inventory, which assesses positive mental health as well, and then the SCL-90R. And, there are, of course, other instruments I listed early on in one of the slides, the BECS, et cetera, that are super helpful in looking at current state of mood. And then I just wanted to end with this slide about thinking about behavioral failure. There was a physician named Dr. Eugene Karagi who studied patients who were undergoing lumbar discography, and that is an injection technique that's used to evaluate patients with back pain who haven't responded to extensive, conservative, but non-surgical care regimens. The most common use of discography is for surgical planning prior to a lumbar fusion. But Dr. Karaji and his colleagues thought that discography could predict who would go on to develop back pain. Some of the study participants had already undergone cervical surgery or had been diagnosed with chronic pain syndrome, but none had lower back pain at the start of the study. What they found was that patients with poor coping skills, as measured by psychological testing, or with chronic pain were nearly 3 times more likely to develop back pain compared to those with neither. A history of disputed workers' compensation claims also predicted future back pain. But a crack in the disc or a high-intensity zone seen on MRI was only weakly associated with reported back pain, and that result was not statistically significant. So the point is that the structural problems were really overwhelmed by the psychosocial factors, according to Dr. Karaji. So psychological tests can outperform medical tests at predicting poor response to back surgery to reduce pain in this study, and there have been others that have had corresponding or related findings. Okay, we have covered a lot. Sorry for rushing right here at the end, but we are at the end, and I just want to say thank you very much for giving us your time this afternoon. We don't have our emails listed here, but I can put them both in the chat box really quickly in case you do have questions or questions that we didn't get a chance to answer. So before we close, let me do that.
So thank you, Dr. Anne-Marie Kimball. Very thorough.
All right. There are both of our email addresses that you can grab out of the box, or you can find us. We're not hard to find at Pearson. Please let us know if you have any questions. Again, thank you very much for hanging with us today.
Thank you.